I'm Dr. Matt Brunke. I'm a diplomat of the American College of Veterinary Sports Medicine and Rehabilitation, and I'd like to welcome you to VSCR, where I'm the medical director. Today, we're going to walk through a practical approach to diagnosing thoracic limb lameness in the dog. So we're going to look at 4 practical ways to assess thoracic limbs: gait analysis, standing exam, recumbent exam, and diagnostics. Before we begin that assessment, we need a thorough medical history. We need to understand when the lameness began. We may even incorporate video of the dog limping at home to further understand what's going on. After we've done our history, we can watch the dog walk in a hallway, and then for our standing and recumbent exams, I recommend doing them on the floor. It's safer for you and for the patient. So when we start with our standing exam, we can combine the orthopedic and neurological components. I like to start down at the foot, and one of the things we'll look at is how do they place their foot. So we'll do conscious proprioceptive placing, where we place it for them and see that they correct. And then we can do hopping, where we lift the other leg and gently push them to the side and see that they correct. After doing placing and hopping, come up the leg, just feeling for any discomfort. You can do a quick range of motion assessment of the wrist, palpate up the long bones, feeling for any discomfort. So after palpating the radius and the ulna, you can then flex and extend the wrist and the elbow together, or separately looking for discomfort, and palpate up the leg, feeling the shaft of the humerus. At this point, what I like to do is come back and feel both legs at the same time, just allowing my fingertips to feel for symmetry. Symmetry at the level of the wrist, at the level of the muscles here in the Antebreaking, the width of the elbow joints from lateral to medial epicondyle respectively, and at the level of the shoulder joint for muscle circumference or muscle width. Again, if they're using their body equally, they should be symmetrical. If the muscles are asymmetrical, then the one side is atrophied from disuse, is the common issue. And if our joints are not the same width, usually the wider joint is the problematic joint. For feeling for elbow width, I'm feeling from lateral to medial epicondyle on both, and then keeping my fingers in place for their distance apart, comparing them, that we have a symmetrical joint. So to review, less muscle, usually the lame leg, while joint width, the wider joint, usually the more problematic joint. There are 4 areas in the elbow you should be looking for effusion. You want to be able to find the craniolateral, caudolateral, and then craniomedial and caudomedial joint compartments. And in a normal dog, those should be concave. And in Molly's example here, she is convex. She's got a little bit of fluid and puffiness in that elbow joint. What I can then do while she's standing is to try and hyper-extend her elbow and see how she wants to step away. A little sign of discomfort. And I can also check to see for her flexion, and she starts to resist me here as compared to a normal dog. So that's going to make me suspicious that we're dealing with an elbow problem with her. While we are here in the elbow, what I'm also feeling for is symmetry. So the two things of symmetry we want to look at for the thoracic limb is symmetry of the muscle mass when they're standing, which you can appreciate with your hands as calipers at the glenohumeral joint. And in this case, I can appreciate that Molly's left front leg is atrophied more than her, significantly compared to her right. And while she's standing, I can appreciate the joint width. And this is another good key here. Joint width, I can feel from medial to lateral epicondyle of each elbow at the same time and compare those, and you can see that her left elbow is much thicker than her right elbow. That's another sign here that we're dealing with an elbow problem in this dog. And in this case, when I'm comparing left elbow to right elbow, epicondyle to epicondyle, I can really appreciate how much wider Zach's right elbow is. So I come back to feel him, I want to feel and try to hyperextend him a bit while he's standing. And I also want to be able to flex his elbow. We do that, flex his wrist as well. And you can start to see that he starts to lock and get discomfort right here at about 90 degrees. So that's cluing me in that he's an elbow primary problem dog. I'm going to palpate up the shaft of the humerus, feeling for discomfort as I get to the glenohumeral joint and the acromion. And I'll check this when we're laying him down as well, but when he's standing, what I can start to do is just see if he'll let me extend his shoulder, and you can start to see here that he starts to resist me a little bit. He doesn't let me bring that shoulder all the way up into extension. We want to feel the prescapular and axillary lymph node, and then we also want to feel up and down the shaft of the long bones, so the humerus and the spine of the scapula and the body of the scapula, feeling for any discomfort. You can also feel the submandibular lymph nodes and just feel the muscles of the neck for any discomfort. And then we want to assess neck movement. So we're going to lift the head up all the way and bend the neck down, looking for any discomfort. And then passive or active, have them move their head in one direction. And then have them move their head in the other direction. They should have a comfortable range of motion to have their nose reach their shoulder in most cases when moving from left to right. So when I start with a recumbent exam, I'm going to start down at the toes and we're going to work our way up the leg. We can combine both our orthopedic and neurologic exam at the same time. What I look for first with each toe is what's the integrity of the nail. Is there a nail that's split? Is there a nail that is buffed down on the top, indicating neurological scuffing? Is there any instability in each toe? So I look for normal toe engagement, which we all know. If I have a flat toe, to the ground, it tells me that the superficial digital flexor, or SDF, has been damaged, at least in that toe. If I have two or more flat toes, then the tear of the SDF may be higher around the area of the metacarpals on the palmar side. If the toe is flat and the toenail is pointing up, that's an indication that the deep digital flexor, or DDF, is damaged along with the SDF. It is very uncommon to have a DDF tear without an SDF tear. So again, flat toe, superficial digital flexor injury, pointed up toe and flat toe, SDF and DDF injury. When I look at each toe, I also look at how does each joint feel? Does each individual toe feel normal? So dogs that do a lot of breaking, so a lot of herding dogs, older in life, will have a lot of toe arthritis because they've been jamming their toes for years when they stop. So they can be uncomfortable in their toes. They can have sesamoid fractures, so I can feel each individual toe around the joint, feeling for any discomfort or swelling. Toes also have collateral ligaments, so I can also feel for any collateral ligament instability of each individual toe. I'm also going to look at the pads. So I'm going to look for cracks in the pads that could be causing a lameness. I'm going to look in between the toes and feel in for any lacerations or foreign material stuck in there. Specifically in greyhounds, I'm going to feel and look for corns that could be growing out of the pads, as those could be a cause for their lameness. Moving up the leg, I'm going to feel all of the metacarpal bones, feeling for any malalignment or discomfort. You can also be on the lookout here for any bone tumors. It's an unusual place for an osteosarcoma, but they can occur. Continuing our recumbent exam, we're going to approach the carpus. So I want to feel and look at the accessory carpal pad and the accessory carpal bone, make sure we don't have any pain or problems there. And on the dorsal surface, I'm feeling all of the joint spaces. As we flex the carpus, we can make out more of the carpal bones, and we should have these concave areas. When a joint is normal, it should be concave. If it's effusive, those areas may be flat or even convex. So we should have a nice concave joint surface. And now we can check for collateral ligament instability in the carpus by extending the carpus and pushing from the lateral side to check the medial collateral ligaments, and pushing from the medial side to engage the lateral collateral ligaments. Carpal flexion and extension should be checked. So we want to flex from the metacarpals and see that the carpus completely flexes. And we want to extend the carpus. When we extend the carpus, we want the elbow extended as well. This is one of the few joints that will extend past 180 degrees and be normal. In dogs that have a first digit, we want to examine that as well for any cracks in the nail, any ungual crest issues, and also to palpate it. If they have a bony attachment, we want to leave that alone. And we also want to make sure that there's no fracture here. We don't think about dogs commonly using this toe, but a lot of active athletic dogs, dogs that do agility, dogs that do herding, when they are running and stopping, this toe actually does engage. And so you can get tendinitis here of the abductor pollicis longus, or APL tendon, and that can be a cause for presentation to the vet clinic. So don't forget about the first digit. So after we've examined the carpus, we want to take time and examine the Antebreaking. This is an important area in both young and older dogs. In young dogs, they may present for a lameness and they may not have a joint problem. So you may be wondering why they still have a lameness. So what I do in young dogs and in old dogs is I palpate the shafts of the radius and ulna together. and try to be a little individual, feeling along the shaft of the bone for any discomfort. In young dogs, bone shaft pain is a sign of panosteitis. In older dogs, bone shaft pain could be signs of an early bone tumor or metastatic lesion from elsewhere in the body. We also have to think about things like hypertrophic osteopathy. It could be signs of bone pain relating from a thoracic mass. And we also want to feel the tendons as they're engaging the extensor tendons when the carpus is extended, if there's no discomfort, and when we're flexing, that the flexor tendons are engaging and are comfortable. With any leg, we just want to gently feel with very light pressure up and down the whole leg. Sometimes they'll fidget, just like that. But we want to see for any repeatable discomfort, an ultra-light palpation, looking for any hyperesthesia or allodynia as signs of a neuropathic pain disorder. So after we've palpated up the radius and ulna, we now come to the elbow joint. We want to find our landmarks for the elbow joint, which are going to be the lateral and medial epicondyles, and we want to start to palpate around the elbow joint. What we're feeling for here is any effusion. So just like the carpus, the elbow does have compartments that should be concave in nature. And I can start to feel the joint surfaces and how they're going to interdigitate between the radius, the ulna, and the humerus. So I can start to make out the landmarks of the lateral joint capsule, again in a concave area, and come back to our joint areas. So the caudolateral joint space here, and then the craniolateral joint space here in a concave area. Come back here to the olecranon and palpate the olecranon, looking for any discomfort or fracture. We also want to check, obviously, the medial surface. So to find the medial epicondyle, it's the highest point in the elbow. So find the highest point with your finger, and then you'll roll off either towards the humerus or towards the radius and the ulna. So we can palpate here. If we get a fragmented medial coronoid process here as a component of elbow dysplasia, we're going to get discomfort on palpation of this medial space. So you can see I'm putting a fair bit of pressure all around the medial epicondyle and feeling right around the medial coronoid part and not getting discomfort. Again, in this case, I can find my joint spaces and they are concave. If they are flat, then that is already effused. It does not necessarily have to be convex. Any joint that is not concave is effused. That effusion can come from autoimmune diseases, infection, or osteoarthritis, along with other causes. So now we want to look at elbow motion after we've palpated in a static position. Let's look at elbow motion. So normal elbow motion involves the joint above and below. So if we just try to flex the elbow, we can see that the wrist starts to bend with it. It doesn't stay extended. So if I kept the wrist extended, I don't get a real appreciation of elbow movement or comfortable movement. So when we look for elbow flexion, for normal movement, we want to flex the wrist, and we also want to stabilize the scapula. Just keep light pressure, and I'm going to bend all the way moving with the dog and staying comfortable. And what I'm looking for here is we should get a few pointers here. Complete elbow flexion, as you can see, can be sustained. We've been holding this for a couple of seconds. If this is comfortable, they should be able to sustain it. I'm not putting a ton of force. We can also look for visual landmarks for ourselves in that the carpus should be very close to the glenohumeral joint. We could also measure this elbow flexion by coming down the shaft of the humerus to the lateral epicondyle and then down the shaft of the ulna, and we're going to get about 30 degrees. So again, visually, carpus is very close to shoulder joint. We can measure for normal flexion in about 30 degrees, and we can sustain this comfortably. Moving dynamically back to neutral and flexing, my thumb and index finger and middle finger are on the lateral and medial sides of the elbow joint, and I'm going through a range of motion, and I'm not feeling any click, crunch, or any other problems in the elbow. The dog's not pulling their leg back. They're allowing me to stay from neutral to flexion. If I'm suspicious about a damaged elbow, whether a traumatic fragmented medial coronoid process or early signs of a fragmented coronoid process in a young growing dog as a developmental orthopedic disorder, not only do I want to do flexion here, but I also want to put stress onto the medial surface and to the lateral surface of the joint. And the way I do that is we're going to flex and bring the carpus lateral to the shoulder joint and hyperflex, putting stress on the medial surface of the joint, and then coming back to neutral and moving the carpus in as opposed to the shoulder joint and flexing again. So now we're stressing different parts, either the lateral or medial surfaces in more detail by moving the carpus out of plane of the shoulder joint and hyperflexing. So here, carpus outside of shoulder joint, and now here, carpus inside of shoulder joint. As important as flexing the elbow, we also want to extend the elbow. So for extending the elbow, we want the carpus extended as well. And we're going to bring the carpus out to comfortable extension. If we were to look at that visually, we'll come down the shaft of the humerus, not through the middle of the triceps, but the shaft of the humerus to the lateral epicondyle, down the shaft of the ulna. This angle is normally about 165 degrees. We want to gently hyperextend the elbow with moderate pressure and look for discomfort or for the dog to pull their leg back or possibly even to vocalize. This is another way of stressing the elbow joint, looking for problems within it. Problems within the elbow joint can be developmental, so elbow dysplasia as components of fragmented medial coronoid process, osteochondrosis dissecans, and ununited anchineal process. Can all have similar physical exam findings, but we're looking for hyperextension here and still flexing that joint, along with our digital palpation of do we have effusion in this joint or not. So for the scapula, we want to identify both the cranial and caudal edges of the scapula and find the spine of the scapula, as I'm finding it here with my right hand and palpating down the spine of the scapula, feeling for a straight continuous line until we get to the acromion. If we don't have a straight line, it's an indication that we've either had a fracture, have a fracture, or could have a tumor here as well. We want to feel for symmetry of the muscles. So in front of the spine of the scapula, the supraspinatus muscle. We want to palpate that, feeling for symmetry. And we'll compare this in our standing exam left to right. We'll feel there. We also want to feel behind the spine of the scapula, so the infraspinatus, and palpating along there. And we just want to see that the scapula has some readable rotary movement in both directions and that it's comfortable. Remember that dogs don't have a true clavicle. They may have a residual one, but so it should be fairly good movement of the scapula. So after palpating up the shaft of the humerus, we've identified the shoulder joint. We have our landmarks of the greater tubercle here, and coming down the spine of the scapula, we end at the acromion. So now I can feel the shoulder joint. And what we want to be able to do here is check for movement, inflection, and extension. So we're going to extend the elbow and bring the shoulder forward. When we do this, we want to make sure that we are not hyperextending the elbow, as we could get hyperextension elbow pain and misinterpret it as shoulder extension pain. So we're holding the scapula in place and we're extending the shoulder. When we extend the shoulder, we should be able to sustain this stretch for a few seconds comfortably. You're not pulling it away. And this normal extension can be about 140 to 150 degrees. Coming back to neutral, we also want to flex the shoulder. So we're looking at the spine of the scapula, the shaft of the humerus. And first, what we're going to do is I'm going to block the scapula from pulling away. And I'm just going to flex the shoulder, looking for any discomfort. And now what I want to do is engage the biceps tendon. So by engaging the biceps tendon, we're going to do that by extending the elbow joint. And we're going to bring the leg back. And as you can see here, we've got an end feel or a stopping point where she doesn't let me bring it back anymore. And that's normal, right? The biceps is engaged. If I put my finger here on the medial surface in the biceps, the bicipital groove, the biceps starts at the glenoid, passes through the shoulder joint, and then runs down to insert on the elbow. So I can put my finger here, I can palpate that tendon, but I don't feel it until I flex the shoulder and extend the elbow, and now I can feel that tendon engaged. I can feel here for any biceps tendinitis, as the origin of the biceps is often the one that's uncomfortable. You can also feel it engage here in the elbow when you extend the elbow. And so again, biceps tendinitis can be a secondary issue or primary issue. If we see it secondary, it's usually due to elbow discomfort. And then I'll start to just gently feel around the 4 joint compartments, feeling for any effusion, which in her case, I do start to pick up some here in the caudal lateral compartment. I can check for hyperextension of the elbow, which she's a little resistant on, but still lets me get to that. We can see for extension of the elbow. If you don't have a goniometer handy, you can feel down the shaft of the humerus to the epicondyle and then down the shaft of the ulna. So in that case, can't do it with my hand. It's about 165 degrees is normal elbow extension. We can also flex the elbow. And when we flex the elbow, we want to flex the carpus. And what I can do here is I can put my finger down the shaft of the humerus, my thumb down the shaft of the ulna, and glide with that. We can start to see right around here, she starts to resist me. If I start to hyperflex, she pulls the leg away. So we could have an idea and measure this If your elbow works normally, the carpus should be able to touch the greater tubercle. And if I start to do that with her, she starts to pull away. What I can do is I can have my thumb on the lateral epicondyle and my index finger on the medial epicondyle in the medial joint space. And what I want to be able to do is just feel that range of motion, what's comfortable. I can feel crepitus in this joint, so there's some crunching. I want to have the carpus extended as well. And we could measure that with a goniometer. Normal elbow extension is about 165 degrees. And by eyeballing this, I know he's in that range. In contrast, then we can check elbow flexion. So we're going to flex the wrist and we're going to flex the elbow. And you can see here where he's going to start to restrict. My index finger is on the shaft of the humerus. And now my thumb is on the shaft of the ulna. And you can see that he resists elbow flexion at about 90 degrees. Normal elbow flexion is 35 degrees. So this is a very limited patient. Also, when I'm palpating him, you can notice that I'm not really gripping down hard at all. I'm just allowing what he feels to be comfortable. I don't need to try to jam this thing all the way closed. Palpate down the spine of the scapula to the acromion. Feel the greater tubercle. And then what we want to be able to do is extend the shoulder. So we have the leg up in the same plane as the glenohumeral joint. And we want to extend the shoulder forward without putting a lot of pressure on elbow extension. This way we're isolating just the shoulder joint for extension. And we can see that he even gets a little uncomfortable here where he starts to pull back. He does not let me sustain this end range of stretch. He starts to pull back. So for the bicep stretch test, first we flex the shoulder, then we extend the elbow, and we start to bring that back looking for an abnormal, either a stop and discomfort or an abnormal end feel. And in this case, you can see how much this dog has increased and no end feel here. This is all able to be brought back. That's an indication of either a biceps tear, or in this case, this dog has had a biceps tendon release surgical procedure. As part of the recumbent exam for the thoracic limb, we want to do some neurological reflex testing. So we can do our biceps test where we can protect it with our finger and hammer away. You can also try it. Sometimes we will get, there we get a good reflex. We can also do our triceps reflex and get a bit here. We want to do pain perception and withdrawal as part of our neurological testing for the thoracic limb. What we're going to look for is movement and flexion of the wrist, elbow, and shoulder. So here's our withdrawal test. And that's nice and normal and complete. We can also, of course, pinch with a little bit more pressure and look for a pain response. And they may visualize or pull away or vocalize. So after we've done our physical exam, a good screening tool is plain radiographs. These are extremely important because not only can they pick up some subtle changes that we can see, but they also help us as clinicians to rule out other processes. We never want to assume that we're dealing with arthritis and miss a chance to diagnose a tumor, as the prognosis are much, much different. So here we're looking at lateral radiographs. We have a humerus, radius, and ulna here. And what I look for with these is, do we have a congruent elbow? So what does that mean? Do we have a nice smooth joint space with no changes in gaps between the radius here, the ulna, and the condyles of the humerus? Again, we're looking for our normals. So we want to look here in our ulnar notch. We should not have a lot of sclerosis, which we don't. And we also want to look for joint edges. So we're looking all around this joint for nice smooth edges out to the olecranon, coming back around here at the humeral condyle, parts of the radial head, and here in the area of the medial coronoid process. Everything here is nice and smooth. If we compare that to the radiograph on the other side of the screen, we see a lot of differences. First and foremost, we can appreciate how white or sclerotic this part of the ulna is. That is a good indication of changes within the elbow joint, and also how irregular the joint surface here is. So we can really appreciate all these small osteophytes as compared to the smoothness of the surface here. Coming back to the arthritic joint, we can appreciate osteophyte formation here on the humeral condyle, and here on the humeral head, and even some sclerosis and change through the radius. Here with Molly, we have a lateral and an AP of her affected elbow. We have our humerus, radius, and ulna, and we can appreciate our changes for osteoarthritis. So we have sclerosis of the ulnar notch here. We have a large osteophyte here, and some osteophyte change here off the radial head. Molly also does not have a congruent joint. So if I trace her elbow here, we have a nice joint space, and then it falls apart, it collapses, and it's much narrower here on the back side. Molly has a little bit of arthritis here at the back of the elbow, but not as much as she does up front. Coming over to her AP view, we now have the humerus at the top of the screen, the radius, and the ulna, and we can appreciate a lot of different osteophytes on this view. Here's an osteophyte here, an osteophyte here, and then we can even have some osteophytosis or enthesophytes, which can be mineralizations of the tendons around this area, and we even have some changes here. So she's got a fair bit of change in her radiographs. We have laterals of each shoulder joint. To orient, we have our scapula here. You can even see our acromion and our nice smooth shoulder joint of the here, and we can even appreciate the biceps groove with no real sclerosis or inflammation. Nice normal shoulder, no real osteophyte formation, and a nice normal caudal humeral head. Comparing that to the opposite shoulder, we have a lot of changes. In this shoulder, we can appreciate some sclerosis around the biceps groove. We can appreciate some osteophytes here off of the glenoid, as well as a large osteophyte off the caudal glenoid here. This large triangular shaped osteophyte as compared to the normal glenoid on the opposite shoulder. Coming back to the affected shoulder, we can see that we have a loss here of the caudal humeral head, and actually this flap has fallen and is down here in the bottom of the shoulder joint with mineralization and attachment here. So juvenile radiographs can be very challenging to interpret. This is a 7-month-old German Shepherd dog who presented for a unilateral forelimb lameness. And this is actually a radiograph of his unaffected leg. So to orient you, we have a lateral film, so we have the humerus up here, the radius, and the ulna. He's only 7 months old, so a lot of his growth plates are still open. Here's the proximal radial growth plate, or physis. Down here is the olecranon physis, separate center of ossification. These are all normal at this age. And even here in the distal humerus, a normal physis. What has closed, because he is now 7 months old, is his separate center of ossification for the anconeal process, because we cannot appreciate it here. Again, here, as I'm tracing out, is our anconeal process, and this separate center of ossification has already closed. This is the lateral radiograph on the affected limb from this 7-month-old German Shepherd puppy. Again, humerus, radius, ulna. We can appreciate that his proximal radial growth plate is still open. We can appreciate, as compared to the other side, that his olecranon physis is still open. And as well here in the distal humerus. So it's always helpful with juveniles to take views of the unaffected leg to look for what normal is at that age. What's abnormal with this dog is right here. He's 7 months old, and this physis here of his anconeal process is not attached and not closed. So we have an ununited anconeal process causing a forelimb lameness, causing his secondary osteoarthritis. In review, you've done 4 practical steps today: gait analysis, standing exam, recumbent exam, and diagnostic imaging. Your next step is to get baseline blood work on those patients and start them on pain-relieving medications. In those cases that you've diagnosed osteoarthritis, next steps include discussing weight management when appropriate and long-term management of their arthritis, which may include advanced therapies. Thank you for watching today. For more information, please contact Exubrion Therapeutics at info@exubrion.com.